right, Nick? I think it's the quickest I've ever been to work. I was like, God, I've been through honking at people. I was like the aggressive, rude driver.
Where do you come from?
I live between 44th and 45th on Avenue, so just by the high school.
Oh, okay.
So not too far. But then the park is like.
I think parking's Byron, can you guys hear us?
Well,
I'm sorry?
Can you guys hear us?
Yes, ma'am, we sure can.
Is everybody there and ready, or are we still waiting on a few?
Cordella will be joining. Yeah, she'll be joining us just a few minutes, so you can go ahead.
Okay. That sounds like Byron.
Yeah, how are you, Jeff?
Good, good. Well, thanks for coming, everyone. Dr. Kaiser's not here right now, but he might pop his head in. So I understand Dr. Kaiser gave a lecture a couple weeks ago about OIs, or opportunistic infections, and he asked me to do several case studies based on that. So this will be open discussion. When we talk about differential, if you have any questions, feel free to stop me and, or we have comments, feel free to stop me and ask. So before we go over that, this is something we don't, to be honest, we never talk about in clinic. I think Byron and I would even go over this, something we don't dwell on. But there is, AIDS, there is an HIV/AIDS classification. And I think it's important to know that basically patients that are considered to have AIDS is anyone below 200, that's why this is in blue, or anyone that has, no matter what their T cell count is, if they have an AIDS-defining illness, which is clinical category C, then you're considered to have AIDS. So if you have a T cell of, like a patient I saw last week who has a T cell of 400, and he has Kaposi sarcoma, which is an AIDS-defining cancer, then he is considered to have what we used to term full-blown AIDS. And we'll go over each clinical category. And the importance of this is, in general, your CD4 count, if you have one CD4 count, that tells you, and a patient comes in with specific symptoms, if you know their CD4 count, you know what they're going to be at risk for, and your differential is going to be expanded, as opposed to if someone comes in with a T cells of 500 and they have a sore throat and a fever, you're less worried about some AIDS-related complications than, the run-of-the-mill things that anyone could have. So clinical category A is a patient who's asymptomatic, or a patient that has what we call PGL, or persistent generalized lymphadenopathy. And that's typically a new patient within a couple years of diagnosis who has persistent lymphadenopathy. Usually it's extrainguinal, greater than 1 centimeter, symmetrical adenopathy, usually cervical, tonsillar, submandibular, and as long as it persists for more than 3 months, that's that diagnosis. That tends to just go away over time while the CD4 declines, or after someone starts antiretroviral therapy, that tends to go away. And then if someone has acute HIV infection or acute retroviral syndrome. Clinical category B are not AIDS-defining illnesses, but they're predictive of someone progressing. So these typically occur in patients that have CD4 counts below 500. And that's often why people get diagnosed. For example, a woman with recurrent vaginal candidiasis who doesn't have diabetes should always think about HIV. Certainly, someone has recurrent thrush or even one episode of thrush, and they're don't have diabetes or not on inhaled steroids or antibiotics, then always think of HIV or testing for HIV. Cervical dysplasia is category B. Non-specific symptoms like fever, diarrhea, and weight loss that occurs over several months, that would be clinical category B. Peripheral neuropathy from HIV. Bacillary angiomatosis is something we don't see very often. Maybe one case in 10 years that's related to Bartonella infection. It can cause this red to violaceous purple nodules on the skin. It's also can cause liver disease. And then if someone has what we used to term HIV-related thrombocytopenia, that's a clinical. It's not AIDS-defining, which it seems like it would be, because oftentimes in the past that's what would prompt treatment. Someone would come in or get diagnosed because they presented with new petechiae all over, and their platelets were 20 and their T cells were 300, and that's how they were diagnosed. I haven't seen that in a while. We do see, so you'll see patients with HIV with, platelets counts of 100, 150, even though they don't have liver disease. And it tends to get better over time with treatment. A clinical category C are some of the opportunistic infections and malignancies Dr. Kaiser went over last time. And that includes esophageal candidiasis, disseminated fungal infections, CV retinitis. So if someone has a herpes ulceration, whether it be genital or perianal or oral for more than a month. TB, whether it be pulmonary or extrapulmonary, as in, I'd say, pleural TB or skeletal TB, what we used to call PCP. Now we call pneumocystis jirovecii pneumonia. Chronic diarrhea from cryptosporidiosis, azospora, which is something I've never seen. That was probably more in the pre-heart era. Kaposi sarcoma, we still see lymphoma, whether it be Hodgkin's or non-Hodgkin's. Disseminated Mycobacterium avium complex, which is a Mycobacterium avium and Mycobacterium intracellulare that causes a disseminated infection. PML, which is called progressive multifocal leukoencephalopathy. Basically, it sounds like what it is. It's a terrible disease of the white matter that patients develop with advanced AIDS, develop these thick white plaques in their brain and develop ultramenostatus and cranial nerve deficits, and basically it's a pretty progressive illness without HIV therapy. Toxoplasmosis of the brain, recurrent bacterial pneumonia. We often forget if you have more than one bacterial pneumonia, community-acquired pneumonia in a year, that's AIDS defining. Wasting syndrome, which we don't see very often. Typically when someone has that, there's an underlying infection or malignancy that hasn't been diagnosed yet. Something I haven't seen in a while is recurrent salmonella bacteremia and HIV encephalopathy or HIV dementia. So let's go into the case studies. The first one is a 33-year-old Hispanic male who has seen you in Beaumont in your clinic to establish primary care. He was diagnosed with HIV 2 months ago when he went to the ER for sores in his mouth that resolved, which he thinks is nystatin suspension. Today he complains of a new sore throat for 2 weeks, as well as some chest pain and some retrosternal dysphagia. He's not had any HIV-related lab work performed yet, so he's brand new diagnosis. No medications, really no other past medical history. On ET exam, you see this white, cheesy, confluent plaques of the entire soft palate extending to the hard palate. On his abdomen, he has some epigastric tenderness. So what do you think, what would the diagnosis be in a patient with HIV, a known T-cell count, and white plaques in his mouth? Anyone?
Good guess.
You tell us, Jeff.
Okay, so it's more likely if he has HIV and he's got these thick white plaques in the back of the mouth, probably candidiasis.
Yes.
Correct. And the key thing with him is it's more than just throat pain or some, when you look in his mouth, it's in his buccal mucosa, but he also has dysphagia. So generally speaking, that's going to be esophageal candidiasis as well. And if that's the case, that's a big issue, because if he has esophageal candidiasis, more than likely his T-cell is well below 200. You guys have seen thrush plenty of times in people on steroids, inhaled steroids, or out of control diabetes, and they probably can get esophageal disease, but not very often. So that is a predictor of more severe disease. Although if he just, maybe he has dysphagia from reflux and chronic reflux and heartburn and has a stricture or something. So it's just because someone has thrush in their mouth and dysphagia doesn't mean it's esophageal candidiasis, but in the clinic setting, as opposed to inpatient setting, you're going to just treat empirically for that. If they were really sick and unable to swallow, or tolerate any foods or liquids, you'd have to admit them for, further workup and possible endoscopy. So in an AIDS patient who, actually, let's go over this a little bit more. So more likely it's what we call oropharyngeal candidiasis. Again, CD4 is likely less than 200. So if this guy more likely has AIDS, has esophageal disease, how would you treat him? Any guesses or thoughts with what medication?
You talking about which HIV med or which?
Or what antifungal?
What now?
Yeah, what antifungal might you use? Would you use the nice
Antifungal. I got you. Yeah, I mean, I would probably want to give him some fluconazole,
exactly.
oral fluconazole.
Yeah.
Okay.
The reason is just because it's more severe disease, easier to tolerate. Exactly. That's exactly right. So again, canisis, you guys are familiar with it. Sometimes you'll see it just on someone will come in with a white coated tongue and it's a little sore and it's like, I don't know if that's thrush. If it's bulky or cheesy looking, or if they have more pain, then often that probably is thrush, especially if you see, lesions, similar lesions in the buccal mucosa or the hard soft palate, on the uvula or in the gingiva. Normally, oftentimes it's painless. Most of the time it is, but sometimes you get this real inflammatory thrush, and especially if it's new, brand new, and it happens acutely, it can be pretty sore, where someone comes in thinking they have strep throat. If it's on the sides of the tongue and it doesn't scrape off, that often can be oral-hairy leukoplakia, which is caused by the Epstein-Barr virus, and that's kind of usually small, like less than half a centimeter, like what we call serpiginous, meaning snake-like white plaque, like just regular leukoplakia that you might see in a smoker that you worry about cancer. And a patient with HIV on the lateral tongue, that's almost always OHL. In fact, I haven't seen it for years. So we see it more back in the 90s when we were delaying treatment. So more patients were running around with T cells of 300 or so, where we see less of that now. And before people started getting bone marrow transplants, that was really mostly just seen in people with HIV. And now in bone marrow transplants, you can see it. And there's really no specific treatment other than HIV therapy. Again, esophageal disease can present with dysphagia, but also odynophagia. And when someone has odynophagia, meaning painful swallowing, or even just have dysphagia, you always have the differential in someone with AIDS isn't just thrush. It should include CV esophagitis, which is AIDS-defining cytomegalovirus. The only way to know that is to do a upper endoscopy and see ulceration, or esophagitis, do a biopsy and see it on pathology slides, or hepatic pathology, where you can grow that virus, and that is, or see it on path and be diagnosed with that and get specific treatment. CV can grow, but CV can often be it's a colonizer. So if you have we just saw this yesterday in someone who has a recurrent or progressive pneumocystis, and someone did a CV culture from their lungs, and the question is, do they really have CV pneumonitis? But it's not like they did a transbronchial biopsy and saw the organism; they just grew it, and that's not necessarily the cause of the pathology. The other would be something seen several times this year, and that is large aphthous ulcers in the esophagus that can be, basically canker sores, but gigantic ones in the esophagus. We had one patient a couple years ago that extended, it was about 17 centimeters from his lower esophagus to his mid-esophagus. And they often are like 3 to 5 centimeters in diameter and usually cause severe pain. If it's really severe pain, usually it's not going to be esophageal canisis. It can be, but usually it's not. That's kind of a tip-off that there's something else going on. So here's a kind of classic picture of someone with these scattered white plaques on there, and that really looks like thrush on the tongue. Like if you just saw that on the tongue, that could, and it's not exactly white because it's smoke or food. It gets color. Here's one where it's like a red patch with the white exudate on, which is something you don't see very often. That's kind of a classic appearance.
Yeah.
And then real thick, severe disease where you have this exudative type of thick, membranous type of lesion. I like to hope uvula is covered. Now this is a patient, or one of our patients from a few years ago, that had severe Candida esophagitis and was hospitalized and got IV antifungals. So you can see throughout the esophagus these big white plaques, even into the larynx. So mild disease, if someone just has a few spots, and it's sore, you can use topical antifungals like nystatin. I don't know if they even make Misolax or Trimazole Troches anymore. But
I remember those.
Yeah, it's been a long time since we were.
Right.
Yeah, back in the 90s, the fluconazole had just come out. Other than that, we were kind of stuck. We used a lot of mycetotroches. Nowadays, if it's, if their throat is sore, if they have significant disease at all, it's just easier to use fluconazole.
Yeah.
It's a pretty benign drug. There are some drug interactions, but I've never seen any toxicity in 23 years with it. I've seen one person have an allergy, but other than that, and we use a lot higher doses for cryptococcus and some other fungi. So usually 100 milligrams once a day for 7 days is sufficient. If you have esophageal candidiasis, the patient does, then they need at least 200 for 14 days. If it's refractory, you might do higher doses. If it recurs or someone can develop resistance to candida resistance to fluconazole. Itraconazole is an alternative. It's not really the capsule. 2 pills twice a day doesn't have great bioavailability as opposed to the solution. And the solution also has a topical effect, so that tends to be really effective if someone can tolerate it. And then there's more severe cases. There's the IV amphotericin. There's the lipid complex versions, and then the newer antifungals that I can't even really keep up with. There is normally candidiasis is caused by Candida albicans. But Candida glabrata it presents just like regular thrush, but it's inherently resistant to fluconazole. So this is where this would happen if someone, T cells are going up and they're undetectable and their thrush hasn't resolved. Sometimes it could be from, a resistant organism. Back in the 90s, we'd have more people were taking fluconazole daily for prevention or taking it frequently and could develop fluconazole resistance and then have to go on to other agents, which was very problematic. So we had people basically die of oral thrush in the past, but not so much anymore with the newer antiviral agents.
Okay.
So case 2, he's never turned out the way on the screen like they should do at my home. But anyhow, this is a 45-year-old white male who has known AIDS and a long history of poor adherence due to primarily from substance abuse and mental disorder. Presents to your clinic with the following symptoms that developed 3 weeks ago: worsening dry cough and progressive shortness of breath on exertion. He can only walk 1 minute without having stopped to rest. He has subjective fevers, rigors, anorexia, and weight loss. He denies having a new rash or lymphadenopathy or chest pain. His last CD4 count was 101 3 months ago. He hasn't really taken his meds well since then. That includes Truvada and Proscovix. He also has been taking Bactrim and citalopram for depression, but not regularly. So essentially not on any meds. On exam, he's wasted appearing, has a low-grade temp, tachycardic, tachypneic, blood pressure is a little bit low, and is hypoxic on pulse ox at rest at 87%. He has some thrush, and on a lung exam, he didn't hear any crackles or wheezing, but he had really poor lung expansion, just could open up his lungs, decreased breath sounds throughout, and he was slightly cyanotic. So clearly a pulmonary process going on. Here's his chest X-ray. That would be not a normal chest X-ray.
That's correct.
Yeah, any comments on that X-ray or would interpret it? What do you see?
Well, I do know this. I know that looks like PCP pneumonia.
Yeah, absolutely. And
yeah, go ahead.
Yeah, so so PCP is usually not a focal pneumonia. It's usually diffuse interstitial. We call it interstitial purine infiltrates. So where you can't, and it's usually diffuse again and bilateral. Can go from the bases up into the apices. Sometimes it'll be central around the the hyaline, but normally it's more diffuse. Yeah, you can see that in his case. Now this is a interstitial pneumonia. There's other things that could present like this as well. So more likely diagnosis. So if it wasn't pneumocystis, what other things could present with an diffuse interstitial pneumonia?
Well, I mean, you could have a viral syndrome, but
like influenza could do that, or some other virus. Yeah.
Right. What I don't know. So.
So mycoplasma.
Oh yeah, atypical. Yeah, mycoplasma. Yeah, absolutely. He smoked cigarettes, probably. So
Yeah, exactly. So yeah, Mike, think of atypicals. Mycoplasma, typically the X-ray looks way worse than the patient, so this would not be a
yeah,
mycoplasma case. This would be influenza, could definitely present like this. It often resembles pulmonary edema, so you have to think of if the heart was
yeah,
enlarged and had risk factors for heart disease, you think of that as well. So yeah, the most likely diagnosis is what we used to call PCP. We'll talk more about that in a few minutes. Now we call it pneumocystis ehrlichii.
PJP. Okay.
And that's more likely that just based on his symptoms, and we'll go over more of that, due to hypoxia, on pulse ox, he probably has a blood gas with a PO2 that's below 70, so more likely he would require steroids in addition to IV Bactrim, and if some of his other vital signs, kind of point to possible admission to ICU. Once they're this sick, they're pretty fragile, and you can overload them with fluid pretty quickly and get fluid overloaded and end up causing pulmonary edema and into the ICU. So obviously these folks a patient like this would you would want to quickly get to the emergency room and consult pulmonary for possible bronchoscopy. Kind of a key point is, as far as pneumocystis, it's previously was carinii, and then they looked at it further. They cited that carinii, the pneumocystis carinii species, causes diseases in rats, and the disease that causes, or the organism that causes disease in humans is Yerevecki.
Okay.
Now, but I still call it PCP or PJP, just kind of depends. The one will chastise you for calling it PCP. Initially, they thought it was a parasite protozoa, and it's actually classified as a fungus now.
Okay.
A factor is a patient in our ICU right now who has progressive PJP despite Bactrim and steroids. And one of our fellows had found some literature about using an antifungal agent in the setting of PCP, but I've never seen that done. Usually people respond to Bactrim or some alternatives options. Okay. It's still the most common opportunistic infection. So patients will still, without an AIDS diagnosis or less medical history, will show up in the ER with, brand new cough and fever and that X-ray, and eventually found out they have HIV and AIDS. Or patients like this that are non-adherent will show up with it. Some of those patients we can treat as outpatient because they'll come in with similar symptoms but not as severe, and they've had pneumocystis before and we're pretty sure it's that. But you have to keep in mind things like even histoplasmosis can present this way, and as we mentioned, other infections. So treating empirically can be problematic, but it's often done just kind of out of necessity. So kind of classic symptoms, it's a subacute illness, so it doesn't present like a community-acquired pneumonia where you have an abrupt febrile illness with chest pain and productive hacking cough. It's more of a progressive illness over several weeks. I've seen it even over several months, where it's primarily a dry cough. And that's why you end up having to do bronchoscopy, because it's hard to collect sputum that is representative of the lower respiratory tract, so you can do a cytology exam and see the organisms on special stain. Rarely do you get that diagnosis that way with pneumocystis. But anyhow, again, it's a progressive illness. The shortness of breath just gets worse and worse over time, and they'll have fever and anorexia like this patient did. It can present with especially if you have recurrent PCP. There's pneumothoraces or source associated with it. Chest X-ray classically is bilateral interstitial infiltrate, and especially on CT you see this ground glass appearance, and eventually it can cause like cystic changes on the chest X-ray. As far as lab work, it's nothing specific other than, well, there is nothing specific, but LDH typically is increased from lung damage, but it's not generally over 2,000. Generally it's going to be 900, 1,000, or around that range. And folks can be hypoxic as this patient was. Definitive diagnosis is bronchoscopy and doing a washing and then seeing the organism. In patients that have recurrent or progressive disease or the bronch was negative, they might need a transbronchial biopsy. The patient that I mentioned earlier might have a superinfection by CMV, and that was described in the 90s a lot, where someone would have pneumocystis start to get better, then develop a cytomegalovirus superinfection, that present similarly, like can cause progressive interstitial changes. And the only way to diagnose that is a transbronchial biopsy. So this is kind of a classic case of pneumocystis. Sometimes it can be more subtle if someone's taking their Bactrim on and off, and and then it's a little more tricky to figure out. But this is the more typical presentation. Here's another chest X-ray where it's more interstitial disease, but in the bases as opposed to the kind of throughout, like the last patient. And this one, if you can see it, more diffuse disease, but especially in the left, mid lung and left upper lung, you can see it.
Okay.
Kind of just a fine infiltrate. And that more like looks like that person was in the hospital. Usually they tend to be less ill.
Right.
So treatment for severe cases are IV Bactrim initially, and then transitioning to PO Bactrim, which is weight-based dosed based on the sulfamethoxazole component. So typically folks will be on 2 double-strength Bactrim as an outpatient, at least 3 to 4 times a day. Over the years, we traditionally did twice a day, which is probably lower than what's in the textbook. Since the faculty's changed over the years, you'll see more folks on 3 times a day, but 4 times a day is a lot to ask with taking Bactrim. That can be pretty tough on your stomach. So especially if they get over those first week or so of IV and they get on Bactrim twice a day or 3 times a day, they do perfectly fine. It's a total course of 21 days. If someone is allergic to Bactrim, which we have a large percentage of, sensitization is important. That's often something we do. Well, used to do. We haven't done that in a while. IV pentamidine is an option, but pretty nasty drug if anyone's familiar with it. It can cause pancreatitis and dysglycemias, and it can be pretty tough. So the alternative next to Bactrim usually is clindamycin IV, followed by PO primaquine, again for 21 days. I mentioned earlier if someone is hypoxic with a PO2 under 70, or if they're older and already have COPD, they're more likely to progress. So steroids is always critical. And they clearly do better when they get steroids. And that's something you would taper over the 3 weeks. So there is primary and secondary prophylaxis. So if someone has pneumocystis and they just found out HIV, they get treated and stay on Bactrim, that would be secondary prophylaxis. The most common scenario is someone happened, like our patient earlier with thrush, T cells are low, you need to start Bactrim. And that would be double strength, 1 daily, Monday through Friday. I'm not sure how they figured out, or if that was just kind of arbitrary thing they did 25 years ago, and that's what it's always been. Some people take it every day, some people Monday through Friday. And it's very, the rates of recurrent PCP on that, or developing PCP on prophylaxis is pretty low. The alternative is dapsone if someone's allergic to Bactrim or intolerant, or if they have, kidney disease and recurrent hyperkalemia or neutropenia, or, that can be a problem with Bactrim. Dapsone is a drug used for leprosy and spider bites. It's very well tolerated, 1 PO daily. Patients that are African American should have a G6PD screen, because patients with G6PD deficiency, if they take dapsone, can develop a hemolytic anemia. I've certainly seen that over the years, and rarely it's associated with methemoglobinemia, but it's been a while since I've seen that. That's usually at higher doses. No one uses the aerosolized pentamidine anymore, at least in our clinic, because you have to have a special room and tent, and it's just kind of a pain. So respiratory therapy, basically, and patients aren't really that adherent with it, coming in monthly for pentamidine treatment. So we did it a lot in the 90s. So if someone is intolerant to Bactrim and dapsone, or let's say they're G6PD positive and you can't use dapsone, atovaquone suspension is an option that works very well.
Okay.
It's 2 teaspoons once daily. It's also used for treatment. Like if someone has mild to moderate pneumocystis and can't take Bactrim or clindamycin, you could do atovaquone. It looks like bright yellow paint, and some people tolerate it really well as far as it tastes. Some folks don't. I have a number of patients who just refuse to take it, and their T cells are 150 and they're undetectable, and they're not likely to get PCP. There's something about being undetectable, despite having low T cells, that people still do well, even though we would encourage them to take something. But anyhow, prophylaxis can be stopped in patients that are taking HAART that is successful if their T cells are over 200 for at least 3 months, and then you can safely stop it, and the likelihood of it recurring is very low. So case 3 is a 30-year-old black male who presents to clinic for an urgent visit. He was hospitalized 1 week ago in Houston for quote-unquote pneumonia. He was diagnosed with HIV, and soon after they told him he didn't handle it very well, and he left AMA. No past medical history, was a former IV drug user last 3 years ago. He's lived in Beaumont his whole life. He complains of a 3-week history of productive cough, shortness of breath, fevers up to 103, night sweats, rigors, anorexia, weight loss, some vague belly pain, and diarrhea. So a little different presentation than the person with pneumocystis. But cachectic appearing like the last patient, febrile, hypotensive, tachycardic, pale mucous membranes. Unlike the last patient, he has some adenopathy, which is unusual in someone with, if you think someone has HIV, that would be unusual if they have a low T cell count. Lungs are clear, belly's a little tender. It does have a big liver and spleen. No rashes, but has pale skin and pale nail beds. So here's the X-ray. Anyone want to comment on that X-ray?
Well, so there's this definite. Is that a focal consolidation on the left?
That's what I was thinking.
So yeah, it's kind of hard to tell for sure in this one without a PA view, which I didn't provide. So it looks similar to the last one, but if you look closely, it has more nodular appearance, especially like in the left mid lung, where you can see kind of those fluffy kind of you're looking infiltrates. So it has more of a nodular appearance throughout the lung, especially on the left side. And that's what this ended up being described as, a reticular nodular, like diffuse reticular nodular infiltrates. Okay. So here's some other hints of what he could have. He has AIDS. As you know, a T cell below 20, cell of 20, high viral load, a white count of only 2,000, anemic, platelet that's low, 78,000, alk phos is probably double the normal value, AST is a smidgen elevated, and actually that should have been ALT is normal, the AST is elevated, LDH is highly elevated, 3,500. Ferritin's very high. That's an acute phase reactant that goes up with inflammation. And he reported having a negative PPD 2 years ago. So kind of summarize him, we have a newly diagnosed guy with AIDS. He has a subacute illness consisting of cough, shortness of breath, fever, sweats, rigors, weight loss, and some GI symptoms. Diffuse reticular nodular infiltrates. So he was admitted, and then we had noted that he had pancytopenia, elevated liver enzymes, kind of an obstructive pattern as opposed to just have the hepatocellular, where it's just your AST and ALT, like you might see with hepatitis B or C, and extremely high LDH and ferritin level. So what would be your differential as far as, in this case, as far as an opportunistic infection?
Well, certainly, the pneumocystis, would toxoplasmosis be one?
Usually toxo is not going to present like with reactivation and pulmonary disease. It's more
That's what I would
see as. But definitely pneumocystis, because severe pneumocystis could mimic this, or he could have this and pneumocystis. Although some of the things that makes pneumocystis less likely are as causing like disseminated disease, for example, would be the big liver and spleen, the really high LDH, the high ferritin, and the pancytopenia. Although a lot of that could be HIV related itself. But definitely a person like this who got admitted would probably be empirically treated with pneumocystis while they're working them up. But there's organisms, especially in this neck of the works where you guys live and where I live, up through the Mississippi, Ohio River Valley, there's a endemic fungi that he's at risk for.
Right.
You know what I'm
Okay.
referring
Which fungal organism? Um, I, not Cryptococcus. Not,
right? Cryptococcus is endemic here, and Cryptococcus is normally presents. It can cause pulmonary disease and disseminated disease, but it's a neurotropic virus, so it likes the brain.
right.
So usually shortly
Okay.
after infection or reactivation, it causes meningitis. So usually before they get to something like this, they have meningitis and are already sick in the hospital.
I don't know, Jeff. What is it? What
Yeah, so
fungus? I know.
histoplasmosis would be
Histoplasmosis.
yeah. And not tuberculosis, like disseminated, TB. It's not really a miliary TB picture where little tiny, little tiny small nodules, but
Right.
disseminated TB would be on your list, or atypical TB, like Mycobacterium kinzaceae, histoplasmosis. If he lived in or had lived in West Texas or Arizona, uh, California, you have to think of coccidio. I can never say that correctly. Coccidioidomycosis. Um,
Okay.
but in this part of the country, histoplasmosis is endemic, and we'll go more over that. And there's some clues on his history that kind of puts you in that direction. But you always have to keep in mind you can have more than one opportunistic infection. And in his case, he did end up getting diagnosed with with histo on a urine histoantigen that came back in a couple of days. They usually, on a patient like this, they do, I just drew a blank on the name when I was working on it this morning, a buffy coat of the red blood cell, and you can actually see the intracellular yeast in the blood culture, or on the blood specimen, and diagnose it right then. But the blood culture would quickly grow histo, and eventually the sputum did. And a patient like this who's extremely ill would be started or admitted and started on amphotericin B immediately. In fact, so some of the key or clues would be the pancytopenia, because you have this infiltrative, fungi of the bone marrow. And but pancytopenia can be from other reasons in HIV. Sometimes HIV itself, um, MAI, which I mentioned earlier on the, I think, second or third slide, can cause a disseminated disease. But it's usually not as dramatic as that. The patients like that are sick over a couple months and have weight loss and vague symptoms, eventually develop pancytopenia. They're usually not as kind of acutely ill as this person. And it generally won't cause like an LDH to be real high and high ferritin, but it can cause the bone marrow infiltration. And that's how you often diagnose MAI, is by bone marrow biopsy. But in this case, he had pancytopenia, high LDH. When you see LDHs in a setting like this, a person with AIDS and a febrile syndrome over 2,000, always think of histo, disseminated tuberculosis, and lymphoma. Those are the three.
Okay.
Yeah, especially those high ferritin levels, like 5 to 10,000. Those are really suggestive of those three things. Now, there's other things that could do it. Even PCP, I've seen it once have an LDH over 2,000, but that generally doesn't happen. If they do, you're probably close to dying. So it's histoplasmosis caused by the organism Histoplasma capsulatum. It's a dimorphic fungus. It's most common in the Mississippi, Ohio River valleys, and all the way down to southeast Texas and extending up to Pennsylvania. So, like, if you were from that area and you visited, let's say Memphis, you could develop like a acute self-limiting pulmonary illness, and someone thinks it's a virus, or maybe you get antibiotics, maybe you don't, and you recover. In patients with AIDS, it's a disease of reactivation usually. So it's endemic. They live in an endemic area. Their T cells drop, and then they develop this reactivation and eventually dissemination. The X-rays are like what we talked about. Diagnosis is through culture or tissue biopsy. The guy had 20 T cells and some lymph nodes. Normally, you're not going to see cervical lymph nodes or axillary nodes that are, that big or a centimeter or more in someone with AIDS. So that would have been like if his cultures were, if he was like milder case, he didn't have like overwhelming disease. A lot of times you'll get a lymph node biopsy and find the organism there. Sometimes eventually by biopsy, because sometimes someone will come in with just pancytopenia, maybe a fever here and there,
Okay.
and it ends up being histo. So it can be really dramatic presentation like this, or more subtle.
Okay.
And the treatment for the sickest patient, and really almost every patient, is IV amphotericin for a week or two, usually 2 weeks if they're severe, followed by itraconazole suspension, again, which is preferred because of higher drug levels. In the prison system, it's very hard to get that. In the what we call the free world, like us, generally insurances will cover it. Medicaid will. You just have to might have to do a prior authorization in the state case, and you can get it on the state program as well. You just have to ask for it specifically. And normally that twice a day will be continued for kind of induction dose, so to speak, for at least 3 months. And assuming the patient's recovering and on HIV meds, you can drop them down to 200 milligrams a day. And then for treatment for a whole year, and then once their T cells have recovered and they've had some immune reconstitution, you can safely stop the secondary prophylaxis after a year. And ideally, you would check like itraconazole levels to make sure they're therapeutic. Repeat a urine histoantigen, which is easy enough. I had a patient recently who basically was the same patient. I kind of stole his info from, and his itra level, he was in TDC or in the prison, and he couldn't get the liquid. He got the capsules, and he continued them as an outpatient. I saw him a couple weeks after discharge, and his itra levels were basically non-existent. But his T cells were higher, like 100, and he felt great. We just kind of left him as, he seemed to be doing great. So it had been 6 months since he had, in fact, was sick. Was probably, whatever he was getting was adequate. So just because the level's low doesn't necessarily mean you'll have to, increase the level. Usually it's an issue because of non-adherence. In his case, I'm not really sure why, because he clearly was responding to his HIV medicine. But generally speaking, the itra level will be, you'll have a decent itra level. So, again, about the histo and difference between pneumocystis, pneumocystis, they're both subacute illnesses, but pneumocystis is primarily just pulmonary involvement. You're not going to have liver and spleen involvement or granulomatous hepatitis or pancytopenia. It's limited to your lungs for the most part, and where histo can, go everywhere. In recurrent histo, we see cases of meningitis as well in recurrent histo cases. Case 4 is last case is a 42-year-old white female with AIDS, advanced AIDS, reports a recent generalized seizure and new confusion. Her history was really limited, but she denied having fever, nausea, or vomiting, but she did have new headaches, and she did not have a stiff neck. She was noted to have pretty profound psychomotor retardation, confusion, and right upper arm weakness, and she was admitted for further workup and had this MRI. So she had this mass, this ring-enhancing mass lesion in her left brain, and you can see a smaller one in the frontal, right frontal lobe.
Right. And
you see the darker, so there's the ring-enhanced lesion. This represents edema. This is to be from toxoplasmosis, which you mentioned earlier. So toxo is, here's the sagittal view, where you can see the ventricle is completely effaced by the severe edema. So someone toxo, well, that's the treatment. We'll go get into the presentation. So normally toxo will present with, like this did, it's more of an encephalitis picture as opposed to meningitis. So someone will come in with 104 fever and stiff neck. Generally they'll come in with confusion, maybe a cranial nerve palsy or weakness on one side or the other, or a new seizure, sometimes just simply confusion, and confusion and headaches. And they'll have single to multiple ring-enhancing lesions. If there's multiple lesions, especially in the basal ganglia, that's kind of classic setting for toxo. And again, these are patients that have CD4 counts below 50. And generally they're not on Bactrim either, because Bactrim is very effective in preventing it. So they often are not adherent patients or newly diagnosed patients that didn't know they had HIV till they presented with this. Or someone that had HIV just didn't get any care for years, and then their T cells plummeted. But how you diagnose this is basically by their presentation and radiographs based on their CT and MRI. And if they have a toxo titer that's positive, which about 50% of us do, that's helpful, although there is what we call seronegative CNS toxo. And you basically get treated empirically, because rarely would someone get a brain biopsy, like surgery would rarely do a brain biopsy this soon, unless there was thought to be like a bacterial brain abscess that was like an extension from the sinuses or something like that. That would be different.
Right.
And if someone isn't, people generally get better clinically pretty quickly because you give steroids along with the antibiotics. And then if the MRI 2 weeks later shows significant improvement, then you're pretty comfortable that it's going to be toxo, because edema will be down from the steroids and the lesions will start to shrink. If it isn't, that's when you have to get a biopsy to rule out primarily lymphoma. Things like cryptococcus can cause cryptococcomas, but that's pretty uncommon. When TB causes brain lesions, it's multiple small brain-enhancing lesions that are all over, a much different type of presentation as well. They'll have other more systemic symptoms. So it's usually treated empirically. And for the most part, that's very effective. Occasionally we'll have someone who keeps progressing and develops more deficits, and the brain biopsy is done early on. And if they have lymphoma, fortunately their prognosis even 2 weeks earlier would have been still poor. So primarily CNS brain lymphoma is something we do see, but pretty uncommon. It's more common in the 90s. And we don't see toxo near as much. We saw a patient yesterday, in fact, who's had recurrent toxo because of non-adherence, and he presented with confusion and chorea. So he had all these, kind of had this really unusual presentation. So treatment is initially IV or PO sulfadiazine, which can be, and it's, either way from 1 to 2 grams, depending on the patient, 3 to 4 times a day. Not real easy because it's several times a day and it's a sulfa drug, but it's critical. The other one would be a loading dose of paramethamine. The other name is Daraprim. That's the one you might have heard about with the notorious CEO, forget his name, that jacked up the price of paramethamine from a few bucks to $500 a pill and got a lot of grief. It was paramethamine. When they say H drug, it wasn't antiretroviral, it was paramethamine. Although it is really pretty easy to get through. It's a bigger issue in the hospital where they have to pay that much. As outpatient, there's programs where you can get it for basically nothing. But it's paramethamine, the one that is that caused out his grief, and now he's indicted for some other problems. He's not our biggest fan. We're not his biggest fan in the HIV clinic, as you can imagine. Folinic acid or leucovorin, it's not folic acid, it's folinic acid, is used to prevent neutropenia caused by paramethamine. If someone is allergic to sulfadiazine, clindamycin is an option. That's tough as well because clindamycin can cause this multiple times a day and can cause GI upset and diarrhea. But some patients will use, for various reasons, will just end up using Bactrim twice a day, and maybe less clear-cut cases, and someone is unwilling to take that many meds. But usually people respond to treatment, and then once they are maybe even 6 months out and their immune system is recovered to some degree, you can stop treatment. You normally would have a follow-up MRI if you're able to get one, which is kind of a problem for some of our Ryan Wine patients about doing that, so sometimes we just go by clinical response. Steroids for edema is critical, and that's usually given over a week or 2. Prophylaxis, for primary prophylaxis, when we're using Bactrim to prevent pneumocystis, we're also using it to prevent toxo. So one last thing is something to be aware of, and it's something we recognized in the late 90s. It's something called IRIS, which is immune reconstitution inflammatory syndrome. And this is I think, to me, the best description I've seen of it, which is IRIS is characterized by worsening clinical, laboratory, or radiographic findings, despite having improvement in the viral load, meaning the viral load becomes undetectable, and improvement in the CD4 after starting HIV therapy. And it's due to restoration of pathogen-specific immune response. So what happens is someone, T cells are zilch and their viral load is high. They start HIV medicine and they start to recognize past antigens or infections they've already, someone's already been exposed to, like varicella or herpes or HPV, or they have recently had TB. And what will happen is you'll have this exaggerated immune response, and someone will have worsening of their cryptococcus. They're seemingly getting better, then they get worse. Or they'll have, most common thing, and I would say about 20% of people that have low T cells that start hard will develop shingles, anywhere from 2 to 12 weeks later. Herpes can flare, and HPV will flare. The two diseases that are most worries that we worry the most about when this happens is cryptococcus, because that can, we've had one patient recently that had recurrent cryptococcus about 12 weeks after first having it due to iris, and despite taking his meds and everything, he had recurrent meningitis and developed bad headaches and high intracranial pressure and had to be admitted a couple times. And then just over time, sometimes with anti-inflammatory stuff, just over time, and continue to treat the infection, this just kind of goes away. But it's something to be aware of and warn patients about, that if they develop if they have a history of herpes or warts, or if that could flare, and you just kind of treat through it and get over it. So if someone comes in with shingles 3 months later, like that's a good sign, even though they're feeling miserable. Again, the risk factors for that are really anyone that gets HIV treatment, but especially those with low CD baseline or pre-treatment low CD4s, if they've had a late infection, meaning they've been exposed to TB in the past, and now they're having a great response to treatment. So again, it's called IRIS. As for some references, if you look at the HIV guidelines, for treatment of HIV, there's a section for prevention and treatment of opportunistic infections. It really hasn't been updated that recently because there's been a lot of changes. But it's a very good guideline, and then the IDSA has a very good guideline as far as recognizing and managing opportunistic infections. And I believe that is the last slide. Any comments or questions?
Do you have any, Jason? I'm just curious.
Oh, no,
No, that's okay. No, that's fine.
I do.
Yeah.
I do.
Yeah, Cordella's here. She does.
Okay.
Yeah. How are you?
Good. How are you?
I'm well, thank you. At the end of the Toxo slide, where you talked about treatment being lifelong,
Correct.
but then it says maybe stopped after they've had some immune reconstitution. Can you explain that? If it's lifelong?
Yeah, and I'll have to look to see what the specifics are. To be honest, I meant to do that before I came in. So for intra, you definitely always treat for a year. For histoplasmosis, you treat, for a year before stopping, even after immune recovery. Same thing for pneumocystis, T cells above 200, you can stop. For over 3 to 6 months, you can stop the Bactrim. Since Toxo involves a brain infection, I've been or like another example of cryptococcus, you can safely stop fluconazole after someone's had a bout of cryptococcus after a year. Some people do it after 6 months, and I was always a little bit wary because, if you have a recurrence, it involves your brain, it could be life-threatening. And I'm kind of in the same fence about Toxo. I think overall they recommend stopping after you've had a CD4 count above 200 for more than 6 months. And to be honest, that should be sufficient. Patients generally are not going to have a relapse of Toxo when their T cells are that high. But, not everyone's going to have that great of a response. They were, they might be older, their T cells were 20 when they started, and they had AIDS for, a long time. And so their T cells are still 100, and they're still taking the sulfadiazine, pyrimethamine, folic acid, or folinic acid. So what you do is you can dose adjust. And there's a lot of wiggle room with that, depending on what expert you talk to, like dropping the sulfadiazine to twice a day. And eventually the pyrimethamine should only be 1 pill a day. So it becomes much less burdensome, but it is multiple pills. but it all depends on what degree of immune reconstitution. And we've had some patients whose T cells, for a couple of years were just hovering around 100 or 150. And I'm like, they're undetectable. They did great. I just changed them to Bactrim once a day, and they did well. I don't know if there's really literature to support that, but it's what we kind of did, because they were starting to become non-adherent and complain about it. So we've done things like that. I'll have to look at the exact guidelines, to be honest. I haven't had a toxo case in a while. That's my patient. But yeah, there's more wiggle room with that or more variability about when to do that. But again, it's this kind of same rule. Over 200 for 6 months, you should be okay. Really, realistically, probably over 3 months. But if someone's tolerating their meds, kind of keep them on it. Clindamycin, that's tough though. Trying to get someone to do clindamycin for a long time. And then it's a little easier now because the HIV therapy is simpler, fewer pills. Back in the 90s, you had 10, 15 different pills with HIV, or total number of pills for HIV meds. Then you added on all these plus other drugs. It was kind of a mess. But it's a lot easier now. And the likelihood of you seeing toxo is pretty rare anyway. Doesn't make sense? Yeah, it's not. I know it's not real specific, but
I know we've had a few cases of toxo here.
oh, okay.
Oh yeah, if you're looking for a disease, come to Beaumont.
Yeah.
Yeah, exactly. Yeah. It's generally like the guy that Dr. Kaiser's followed. His recurs simply because of non-adherence, and eventually it'll catch up with them. And that generally is the case with most of these infections. And this is the whole idea about treating patients, everyone, as opposed to in the past we would treat someone with their T cells below 500 or below 350. So we would see someone and say, we'll see you in 6 months. We'll just keep monitoring, and then they disappear from clinic and don't come back for 2 years, and they come back really sick. So that's part of the other reason to treat early to prevent these infections.
Right. Yeah, because really the cases that I've seen are those who present with AIDS. They've never been tested or accessed treatment before.
Exactly. Yeah.
Yeah.
Yeah, that's a very good point. That's the majority of these cases are those folks that either haven't had care for a while or didn't know they were positive until they presented with toxo.
Yeah.
The woman I'm seeing that's from Africa who moved here after a year developed severe diarrhea and fever, eventually had a colonoscopy, and they found a mass, and it was a histo mass. And then she was diagnosed with HIV. So, she could have come in with hemocystis, but didn't end up having histo. And so she probably got acquired histo while in Texas, and within a year developed, primary disease, which is a little different presentation than most people, but we've certainly seen that. But the main thing is certainly pneumocystis is the most common one that you'll see.
Okay.
All right. Any other questions or?
In terms of the presentation, no, that was great. Thank you very much. It's helpful. Hey, I want to ask you something real quick. Do you need me to send you something? I think you have some flash drives for me or something, or?
Yeah, I guess the pharmacist wasn't here yesterday, so I gave him to Sam, so I'll have Sam give you a call. She was going to.
Okay.
Yeah.
Sam, okay. Yeah, yeah, that's okay. All right, good deal. Hey, another thing, Jeff, you think she could give me these slides? Like, you think she could send me these slides? These are awesome. Huh?
Absolutely. Yeah, I'll have her do that. Or just send me an email and I'll send them to you.
I will send you an email, Jeff.
I was able to email myself because of the pictures. It's pretty big, but
okay.
I'll email it myself. So.
All right. Oh, this was very, very helpful.
All right, I appreciate it. Thanks, guys.
Thank you. Have a good day. All right. Bye-bye.
It's so weird to sit in a room talking to yourself.